not only for the patients with renal failure. This is from a study where they looked at postmenopausal women who were taking calcium in order to prevent osteoporotic fractures. And those women taking calcium regularly, the risk of myocardial infarction was increased, and it was increased quite considerably. And in fact, a number of studies have now shown that the risk of myocardial infarction, stroke, or the combination of both is increased if the amount of calcium intake is too high, meaning probably above 1.5 grams per day. So the conclusion is to keep the calcium as low as possible. And in fact, even the endocrinologists who were always propagating the intake of calcium because they really want to prevent osteoporosis and osteoporotic fractures, they've decreased the amount they're recommending to 1.2 grams. Here, for example, the recommendations of the Canadian Society for Osteoporosis. So in summary, calcium should probably be kept within the normal range, and even low serum calcium may promote vascular calcification, at least when the phosphate is elevated above the norm. What do the new, now already also 4 years old, KDIGO guidelines say about it? They say, well, calcium-based phosphate binders should not be used if the calcium is increased. That's pretty trivial. It also says that they should not be used if the PTH is too low, because there may be a risk of adynamic bone disease, and of course, if adynamic bone disease is present, they should also not be used. Sevelamer, of all the possible therapeutic options to treat hyperphosphatemia and vascular calcification, is the drug with the best database, being tested in a number of clinical trials. For example, this prospective study by Block and colleagues looked at the effects of treatment with sevelamer versus calcium-based phosphate binders and mortality prospectively. And the first thing they noted is when the patient was new to dialysis and he had no vascular calcification present, those are the ones in red, then the risk was relatively low. However, in those patients who had vascular calcification, and we've seen that before, the risk was robustly increased. And comparing the groups with the sevelamer-based treatment versus the calcium-based treatment, they saw that those patients with the sevelamer-based treatment had a lower, much lower progression of vascular calcification compared to those patients who were taking a calcium-based regimen. And after 5 years, that was a significantly difference in mortality between the two groups, favoring the sevelamer-treated patients. However, that of course was a small study. It was for 5 years, but the real study lasted only for 18 months. So the large study looking at it was the DECOR study, looking at over 2,000 patients where they had two different groups, over 1,000 patients treated with sevelamer and a little over 1,000 treated with a calcium-based regimen. And unfortunately, only a small part of the patients basically completed the study. That was one of many problems with the study. Now, the study results were negative, which was very disappointing. In fact, there was no difference in all-cause mortality and no difference in cardiovascular mortality. There was a small difference in patients over 65 years of age, but even that was not very impressive. So very disappointing. What could be the difference? Why could be that the DECOR study were negative, whereas many other smaller studies had seen positive results? Well, one problem is that the DCORE study only looked at a relatively short period of time, up to 36 months. Whereas the other studies, for example, the Rhine study by Block and colleagues, which I showed you before, looked at 5 years, and only after 3 years, basically the curves went in different directions. What about chronic renal failure? Because we know we want to prevent that the patient who's new on dialysis develops vascular calcification. Well, again, this is from an Italian study where they treated patients on chronic renal failure with a calcium-based phosphate binder calcium carbonate and compared them with sevelamer. And those patients treated with sevelamer had the lowest degree of progression. There was still an amount of progression, but not very much, whereas those patients who were taking a calcium-based phosphate binder and the controls not being treated had progression of the disease. What about mortality? Last year, that study came out by Diorio and colleagues, again from Naples, where they looked at 239 patients, allocating them to sevelamer treatment and comparing that with calcium-based phosphate reduction. And the results are as following. The mortality was decreased. Okay, the mortality was decreased in the sevelamer treated group, and also the progression rate, something that of course is very important, the progression rate to end-stage renal failure, to dialysis dependency, was reduced by sevelamer-based treatment. Sevelamer has a number of additional effects. There's an effect of lipids, a decrease in lipids. There's an effect on the serum uric acid levels. You heard from Rick Johnson's talk that uric acid level may be very important for cardiovascular mortality, and in fact, sevelamer reduces that. And it reduces certain factors associated with inflammation and endothelium function. So in summary, calcifications are a risk factor for increased cardiovascular mortality, and that is something that is very important. You should look at calcifications in your patients. You should be aware of that. You should talk to your radiologist if he looks or she looks at a chest X-ray to describe the presence of vascular calcification, because it means that the risk of your patient is even more increased than it is anyhow as being a patient with renal failure. It is very common in renal disease. Phosphate is probably the most important risk factor, thus phosphate should be kept within the normal range, maybe even below that, but that is something we can maybe talk about in the discussion. Addition of calcium is a risk factor for vascular calcification, thus the intake should not exceed 1.5 grams. And from all the therapeutic options we have available right now, sevelamer is certainly the one that's best evaluated, although even with that, we lack the clear-cut, large prospective data to support its use. And one final word, cinacalcet may be an interesting add-on therapy, particularly in those patients with resistant hyperparathyroidism, because even that can decrease vascular calcification. And this is basically the final slide. Now I focused on phosphate, of course, but our patient, as you all know, our patients have a lot of problems we need to address as firemen to extinguish. And with that, I conclude, and thank you for your attention. Thank you very much.
Thank you, Professor Frank, for this very good overview and underlining the importance of hyperphosphatemia. It's very difficult to control by diet, yes. And you also made a very important point on underlining the fact that we shouldn't give calcium carbonate as we used to in very large doses, which will promote the occurrence of chronic calcification. Would you like to make a comment, sir? Yeah, thank you.
Do any of the stage 1, stage 2, or whatever, and which drug you recommend to start first? Vitamin D, calcium, or sibutramine?
Well, that's an excellent question, of course, and something we don't have any data on yet. It's probably not stage 1. It may in some patients be stage 2, but in many it's certainly stage 3. Now, what do we address first? There's a strong controversy about that. In Germany, at least, we usually start looking at the vitamin D levels. Now, not having that much sun as you guys have here, there's a high percentage of our population who has a vitamin D lack. So we usually start supplementing vitamin D, the native vitamin D, to our patients. Once the patient develops hyperparathyroidism, then we usually add alpha-calcidol, the hydroxycholecalciferol. And then, of course, there's a big question, when should we start reducing phosphate? Should we start reducing when the phosphate increases? That's what most people do, me including. Or should we start even earlier? You know, some people advocate, well, we should measure FGF23 levels because FGF23 starts to rise even earlier. You know, we know that phosphate levels increase in many patients only at stage 4 kidney disease. So maybe we should look at the FGF23 level and start treating those patients earlier. That's a good story, but we don't have any data on that yet.
Making this point clear because there is this notion that with the early rise of FGF23, and at this stage, stage 1, stage 2, you still don't have a problem of hyperphosphatemia.
Right.
And this issue has been really risen. Should we treat hyperphosphatemia, phosphorus at this level? Or are we using measures that need to be modified into a high sensitivity form of measurement? Because why is fibroblast growth factor rising?
Exactly. That is something we don't know. And in fact, I had a number of slides addressing the FGF23 issue, but it's getting like more complicated every day almost, the FGF23 story.
And are we going to start to treat FGF23 by monoclonal antibodies?
Right, well, who knows? No? But there's certainly no evidence yet.
Okay.
Do you have any other questions? Right.
We had many questions when we were talking.
Just two simple questions, please.
I would like to stress on the dyslipidemia and the elevated levels of LDL in patients on hemodialysis, particularly on Maya syndrome, or without. Because LDL, if it is more than 160 or more and more 130, it helps calcification with the hyperphosphatemia, acidosis, and chronic kidney disease with all the dilemma of this uremic syndrome. So LDL treatment by statins is very important, particularly for ages above 45, for some races, and for chronic kidney disease. And thank you.
Yeah, that's a very excellent comment. That's what I basically had on this last slide. It's not only phosphate, but it's the other factors we need to address as well.
Because of the short of the time, it is my pleasure to introduce the next speaker, Professor Ahmed Al-Khurai'i من جامعة اسكندرية. He will speak to a completely different issue, although we're still in the Sanofi Symposium. It is the control of the hypertension and how can we protect the kidney. Right, Professor Ahmed Al-Khurai'i, تفضل.
Assalamu alaikum wa rahmatullah. Mr. Chairman, dear professors and colleagues, well, I've tried to change a little bit the outline of the title. Maybe after all it's the same topic, but just maybe a little bit different approach, and maybe just stimulating your appetite to our next meeting, inshallah, which will be held in Alexandria with the main theme that will be shown at the end of the slides, inshallah. So we change it a little bit to renal protection versus renal prevention versus renal protection. Where is the evidence? Now we'll try to look for the evidence in a systematic way and a critical appraisal for how can we do that. This was the cause for the change in the title. It's a very nice article published in QGM a few years back, maybe 3 or 4 years back, and it defines renal protection as the common practice of utilizing pharmaceutical agents, especially ACE inhibitors and angiotensin receptor blockers, for various clinical indications that we all know, starting from hypertension, diabetic and non-diabetic nephropathies, with or without proteinuria, of course with the controversy about the last point, with the view to maintain and sustain renal function over a prolonged period that might be beyond just the blood pressure control. On the other hand, renal prevention is a term that will be defined as every attempt to prevent renal dysfunction, which is everyday practice of every nephrologist who is faced by a lot of chronic kidney disease patients that he's trying to halt progression by every mean that he got, like avoidance of nephrotoxic agents, contrast, early and prompt correction of volume depletion, appropriate choice of the dosing of the pharmaceuticals, and as per the author of this review in the Middleford Clinic, that he withhold this ACE inhibitor or angiotensin receptor blockers before specific situation like contrast exposure, perioperatively, during severe illness, and in any setting associated with cardiovascular compromise. So back to hypertension and a little bit to the basis. It's of course a triple paradox. We know very well that it's very easily to be diagnosed and oftenly undetected. Very simply to be treated, but oftenly untreated. And despite the strong available plethora of treatments, it's often ineffective in the management. This is our situation. And although this slide is a little bit old one, but we don't have any recent data about the prevalence of hypertension in the Egyptian population, it's around 26%. Males and females are almost equally affected. Of course, we know that hypertension will cause end organ damage to most of the important organs, starting from the cerebrovascular stroke, the peripheral vascular disease, retinopathy, renal failure and proteinuria, and of course, cardiovascular illness. But the relationship between hypertension and these different comorbidities are very vast and robust. Actually, coronary artery disease showed that 50% of the patient have hypertension actually. In LVH, there is 20% chance to develop increased left ventricular mass if you're hypertensive. And strokes, especially ischemic strokes, of course, had a 77% prevalence of blood pressure more than 140/90 with the first stroke. Of course, in CKD patient, 18 to 15% of hypertensive adults are with decreased renal function. Their GFR is subnormal. Diabetes, 75% added cardiovascular risk in diabetic patients, and this will show tremendous effect if you know that 100% of type 2 diabetes after few years are almost hypertensive, as well as in peripheral vascular disease. And this is the WHO criteria for type 1 for diagnosing hypertension, shows that in both type 1 and type 2 diabetes, there is high prevalence of hypertension even before the appearance of renal disease, with no proteinuria ranging from 40 to 70 between type 1 and type 2 diabetes, with proteinuria coming up to 70 and 80 plus. With renal failure, you would find almost every single diabetic patient with renal failure having hypertension in type 2 diabetes. So let's look for a clinical case. Now we'll make it a little bit based on simple practice, day-to-day practice. The gentleman is 57 years old with type 2 diabetes. He was first diagnosed by diabetes 2 years ago. He had other medical problems, including obesity and hyperuricemia, and he's just coming for a routine follow-up. His blood pressure is 130/80/93 that he noticed. He's a very educated person, and he is asymptomatic. Now, during his physical exam, the blood pressure was a little bit higher than what he reported, and his pulse was okay, no retinopathy, and there is no clinical evidence for congestive heart failure or peripheral vascular disease. His labs show blood urea nitrogen of 14 and serum creatinine of 1.2 milligram per deciliter, uric acid just hitching to the borders, and the random blood glucose was elevated, normal electrolytes and normal TSH levels, and his 24-hour urine collection was 250 milligram per day. Now, based on your clinical practice, what you will do? Would you accept that this patient is a renal patient initially or not? Please raise your hands. Do you think this patient is a patient with a renal disease? Yes, you think he's a patient with renal disease? Okay, not everyone is convinced. So, for those who are not convinced that he is a patient with renal disease, can anyone tell why?
And may suffer of the cardiometabolic syndrome. So if I'm going to tackle every item separately, the whole health may be better. And the lab and the non-lab clinical points may be better.
Okay, you would accept a serum creatinine of 1.2 in a male of 57 years old, which is okay. But how would you explain the microalbuminuric range? Now his urinary protein is 250 milligram per day. And by default, in a patient with diabetes, you would accept that this is diabetic nephropathy in a microalbuminuric range, or you would reject that.
So the cardiometabolic syndrome, part of them is proteinuria, hyperuricemia, obesity, dyslipidemia, just impaired fasting glucose, and all of these dilemma may be in one basket. So mesangial expansion, accelerated angiotensin II, cascade, arrest.
So he has got a renal disease.
All of these are parts together in one basket.
Yes, so he has got a renal disease. You just said he has a mesangial expansion.
And may be reversible.
Okay, so this is an important clinical point that you should look for the patient earlier than others would think. Being a nephrologist, we should consider the patient as a renal patient as early as possible to try to protect him. So next question is, should we treat his blood pressure? Again, to remind you, it was 138/90 in his home, and the office taken was a little bit higher, which is accepted. It was 145/93 or 95. Should we treat or should not we treat? Okay, who would treat that patient for blood pressure? Most of the floor would treat the blood pressure. Okay. So what treatment strategy should we use? Okay, putting aside that we are in a session of Sanofi sponsoring, just spell it out.
Cardiometabolic syndrome is very, very beneficial, whether it is ACE or ARBs.
Okay, who would choose a different agent rather than Rasprolocade? Conservative?
Exercise, I should confirm for that for 3 months.
Okay, lifestyle changes. Lifestyle changes.
There is a last release on Medscape yesterday, and they will accept systolic blood pressure 140 in diabetic patients. This give a more freedom and reliability with doctors in their clinic.
Okay.
So I can wait with conservative therapy for blood pressure per se.
That's what we're calling for, looking for the evidence and critically appraising the evidence. Okay, just to remind you that within within recent memory, diabetics were denied transplantation or even dialysis, depending on their poorer survival. Now, of course, most of our clients are diabetics. As you know, 50% of patients on dialysis are secondary to diabetes, at least worldwide, and the US 44%, maybe in Egypt. The percentage is a little bit different, but it's definitely increasing. Looking for the clinical feature of diabetic nephropathy, there is a triad of proteinuria due to impaired barrier function, altered glomerular filtration, and increased systemic blood pressure. And this will eventually lead to the proteinuria or nephrotic syndrome at the end, and the renal failure or end-stage renal disease. And this is a history that we all know. It's glomerular hyperperfusion, silent phase, microalbuminuria, overt nephropathy, and end-stage renal disease, and this is where it appears clinically, nearly just before the end. And this is the classical view for the evolution of diabetic nephropathy, where retinopathy will start to appear a little bit like 5 years, and proteinuria will start to move on along from here, maybe 7 years, and start to go up along with retinopathy, whereas GFR initially increasing with hyperfiltration, then start to decline maybe after 15 years. And that's why the screening for diabetics to detect microalbuminuria is a very accepted practice. But recently, not so recently actually, the notion for non-albuminuric diabetic nephropathy has been raised. So not all diabetics with diabetic nephropathy will eventually be albuminuric. Actually, the numbers are not little. If you look for the UK PDS trial, the number of the patients with type 2 diabetes that have renal impairment without albuminuria was almost half. In the DCCT trial, it was around 24%. Even more, some of these were non-albuminuric nor retinopathic, although they have classical histological diabetic nephropathies. So it's getting more complicated. Okay. This might show that a change in the pathogenetic mechanism, as well as the prognostic implication, and of course, the therapeutic measures to be taken. Would we treat all of them together? So the question, after all, which appears initially very simple, yes, we would treat, yes, we would give ACE or ARBs, might not be that easy to answer. Of course, back to the basics, what is the role of angiotensin or angiotensin 2 or RAS blockade in those patients? We all know that angiotensin 2 would stimulate both hemodynamically as well as molecular events that would lead to progressive nephrosclerosis, and this would be fired by the hyperglycemia on a patient with a genetic background, either by metabolic or hemodynamic factor, and alteration of the shear stress and the cytokine, and firing of the whole set of inflammatory mediators. And this might occur due insulin deficiency, elevated glucagon, TGF-beta, which having now very high role in diabetic nephropathies, increasing angiotensin II, of course, that might mediate increase in the TGF-beta level, and other molecules as well. Back to this part of the RAS blockade, just to add on to the diversity of angiotensin II, a relatively new point, which is the intracellular RAS. It's not only the systemic RAS that we know, there is as well intracellular RAS acts as an intracrine manner, and there is AT1-like receptor in the cytoplasm and in the nuclear membrane and chromatin and in the hepatocytes and the mesangial cells. Mainly in the kidney, this would act not only in the glomeruli as we know, but also in various parts of the collecting system, whether the proximal disc collecting duct or even in the loop of Henle. And it would lead to cellular proliferation, podocyte detachment, epithelial cell, fibroblast, and mesangial cells that might proliferate, and giving the specific picture of glomerular lesion in diabetic nephropathy. Now back to the case. Well, this question is to be put. Is that patient diabetic nephropathy or not? Who goes with that patient that he is a diabetic nephropathy? Okay, very few. I mean by his history. بيتفاعلوا معايا بيه عشان بس احنا بلديات يعني. ف who would say that he is not diabetic nephropathy? طيب والباقيين محايدين. طب التريك فين؟ Yes, he only has diabetes since 2 years. Are we allowed to diagnose diabetic nephropathy in a patient with no retinopathy and diabetes for 2 years? Yes or no? Well, I don't know. The differential diagnosis is too vast. Many actually clinical situations that co-present in a diabetic patient can lead to troubles starting from microalbuminuria up to renal impairment. All this risk is on the ride, and even though the basal is old, even in microscopy at histological level, you might biopsy the patient and you're not yet able to say he is diabetic or not diabetic. I mean, it's not always Kimmelstein-Wilson nodules everywhere. So what to do, how to take this furthermore? Maybe looking at the genetic, anticipating who will get sick, who will stay well. Maybe the ACE gene deletion insertion. Maybe some other genetic markers like aldose reductase and others. Not yet settled. Now come back to the case. Should we treat the blood pressure? You've said yes. How we should treat? You've said ACE or ARBs RAS blockade. Well, should we treat? This is the 2009 reappraisal of the European Society of Hypertension, European Society of Cardiology, and they state that when you have a blood pressure of high normal, which is 130 to 139 or 85 to 89, you would not treat if there is no other risk factor. If there is one additional risk factor, you would start by lifestyle changes and then go to intervention if the blood pressure is not settled. And if you have more than 3 risk factors, or if you have organ damage, and we'll hear inshallah to a lecture from Professor Nahas whether proteinuria is a valid endpoint for renal disease. Can we consider this an organ damage? having proteinuria or not. So you would start both lifestyle and drug treatment immediately. How low should we go? Considering that he is diabetic and diabetic nephropathy, we should go down to below 130/80 if we accepted that he is diabetic nephropathy. And this is the position statement. Blood pressure should be reduced to at least below 140/90 and to lower value if tolerated in all hypertensive patients, and to at least less than 130/80 in diabetics and in high or very high risk patients, such as those with associated clinical conditions. These are the National Task Force for Chronic Diseases developed by the NHS and funded by the NICE to develop the guidelines for management of hypertension or chronic kidney disease. They stated that different classes of antihypertensive will reduce the blood pressure to a similar degree. But the number of trials of antihypertensive therapy have shown that reduction of the blood pressure reduces the risk of end-stage renal disease. So we have to reduce the blood pressure. This is number one. They recommend for those people newly diagnosed with hypertension, younger than 55, to start ACE inhibitor or angiotensin receptor blocker. This is the prime drug treatment according to their recommendation, regardless of the renal condition. Those are over 55 or with the black ethnicity should be started on either calcium channel blocker or a thiazide type diuretic. Where the blood pressure remains uncontrolled, additional classes of antihypertensives such as alpha blockers or beta blockers are recommended. Hypertension is extremely common in people with CKD, and the mean number of antihypertensive agents prescribed would be increasing with lowering of the GFR. You would use 2, 3, 4, and 5 agents. Existing guidelines are quite clear that certain antihypertensive agents have specific benefits in patients with additional comorbidities. And it is well known that ACE inhibitor, angiotensin receptor blockers, have additional benefits over and above blood pressure control in people with diabetes. And the United Kingdom CKD guidelines recommended that ACE inhibitor, angiotensin receptor blocker, should be used as the first-line therapy for people with diabetic kidney disease or with proteinuria, having protein creatinine ratio more than 100 milligram per millimole or 1 gram per day, 24-hour urine protein. And this was endorsed by the UK Consensus Conference. And although the evidence is less clear for the non-diabetic kidney disease with lesser degrees of proteinuria, the quality and outcomes frameworks require the use of ACE and ARBs in people with stage 3 to 5 CKD hypertension with proteinuria. Again, for the CARI guideline, the Canadian one, they recommend the regimen including ACE and ARBs. They even got behind this and they recommend the combination in spite of the on-target trial and its result. And the US and European are not any way far from this. They condition favoring their use of angiotensin II are the type 2 diabetes, diabetic microalbuminuria, proteinuria, LVH, and of course when he is intolerable to ACE inhibitor. And the compelling indication are congestive heart failure, diabetes, and chronic kidney disease, most of our patients. Not only that, but the economic studies for the use of angiotensin receptor blockers showed that in different parts of the world, like in UK, US, Switzerland, Canada, and Belgium and France, there is good economic benefit of using irbesartan and along the renal study as well as losartan. Of course, this is the main concern. Creatinine will goes up. If I use an ACE inhibitor or an angiotensin receptor blocker, creatinine might goes up. Actually, this does not mean a lot in matter of survival of the kidney or the patient. It's just a physiological changes that would occur with lowering the GFR. There was significant reduction in the risk of end-stage renal disease with ACE inhibitor and with angiotensin receptor blocker, and this is level 1 evidence. And there was non-significant reduction in the risk of doubling of serum creatinine with ACE inhibitor, whereas it was significant with using angiotensin receptor blocker. Also proteinuria. Both reduced the rate of progression from microalbuminuria to macroalbuminuria, and there was no significant difference between both agents or classes, and both reduced, increased the regression from microalbuminuria to normoalbuminuria. Now we're talking regression with the patient from the microalbuminuric range to the normoalbuminuric range. This was, of course, shown in the PRIME program, which was divided into the IRMA2 and the IDENT. The IRMA2 entailing the microalbuminuric as well as the proteinuric patient, whereas the IDENT was looking after the patient with end-stage renal disease or with renal impairment. There was definite decrease in cardiovascular morbidity and mortality. There was definite regression in the development of overt proteinuria with a relative risk reduction of 70% with the higher doses of irbesartan, and there was normalization of urinary albumin excretion, more so with the higher dose of irbesartan in the IRMA2 trial. In the IDENT, the relative risk reduction of developing end-stage renal disease or doubling of serum creatinine or death was up to 20% between irbesartan and placebo, and up to 23% between irbesartan and amlodipine, which was very bizarre, but this was the situation. So the renoprotective effect of irbesartan are above and beyond its effect on the systemic blood pressure, and this was endorsed actually by the guidelines. Translating this into economy, as we've just shown the table by the NICE guideline, treating 10 hypertensive patients with type 2 diabetes and microalbuminuria using irbesartan 300 milligram per day for 2 years would prevent one patient from developing overt diabetic nephropathy within these 2 years, and treating 15 hypertensive patients with type 2 diabetes and proteinuria with irbesartan 300 milligram per day for 3 years would prevent one patient from developing doubling of serum creatinine, end-stage renal disease, or death within 3 years. Of course, adding hydrochlorothiazide in a dose of 25 milligram, which we don't like generally as a nephrologist, was shown in some trials, like the inclusive trial, to be metabolically neutral. Up to 46% of the patient had metabolic syndrome, and up to 30% had type 2 diabetes mellitus, and they did not have any metabolic troubles with the hydrochlorothiazide. Of course, the systolic blood pressure goal was attained in a higher proportion with adding the hydrochlorothiazide and the diastolic as well. And the conclusion was that the combination of hydrochlorothiazide 25 milligram with irbesartan 300 milligram was more effective to control 8 out of 10 patients to achieve the blood pressure control, and the result consistent across diverse patient population, whether obese, whether metabolically having metabolic syndrome or others. Lastly, I would like to announce for our next Nephro-Alex meeting, inshallah, by the end of June this year, and the theme for this year's meeting would be evidence-based nephrology critically appraised. And thank you for your attention.
Thank you very much, Professor Ahmed, and thank you, everybody. And once more, I'd like to thank Sanofi for this wonderful gathering together, and hoping to see you within half an hour. Just before you go, don't miss a session about how to design, conduct a medical right, and publish your study. That would be from 7 p.m. to 8 p.m. if you are interested, today at level -2.